Good afternoon, Ravi Kiran. You are on mute, please remove the mute.
Afternoon, Andy.
How are you?
Very well, thanks. Miru?
How is your kids, wife?
They're all very good, thank you.
Okay. She is also a student, no? Kiran Mai?
He is, yes.
Yes, okay. How is the things are there? COVID, how you are managing?
In the last 1 week, we didn't report any cases, and not the critical ones.
Okay.
So for the 25-mile radius, there were no critical cases. So I think we are making a good progress.
So you are in safe side now?
No, our district is one of the highest reported cases.
Okay.
But what we have been doing is we have strict lockdown rules and trace and track. So it is virtually impossible for the spread of the virus.
Okay. So how you are protecting yourself?
Myself, we have PPE. So if we are going into the wards, we know which wards actually are the ones with aerosol generating procedures. So if we are at risk, we make sure that we have the PPE on at all times, even in the corridors, even when we go to canteen and stuff. And everything everywhere is separated by 2 meters. If we are not separated by 2 meters, if any person is going to come closer to us, then we need to wear the PPE. That's how we are managing it. Plus, we have alcohol dispensers everywhere. So we sanitize our hands soon after we touch any surface whatsoever. And we also make sure that there are posters and everything available. Hospitals are not allowing any visitors. So there is no chance of visitors coming over. So it's a big army of healthcare professionals who are trained very well in infection prevention. That
Are you handling with COVID patients?
I have been on one of the worst wards for COVID. Nearly 80% of the staff went off sick with COVID symptoms, and they were tested positive. I was working in trauma and orthopedics then. So it's something that you cannot say no to. So if someone actually falls down and hurts themselves or breaks a bone, so for fractured hip in particularly elderly people, we have to, accept them, and they do test positive. And when they do test positive, we actually put them in a cubicle based on where they are with their respiratory rate and based on how compromised they are. We then transfer them to critical care onto a respiratory ward, put them on a ventilator and stuff like that.
Okay, so you are doing a good job there, and by handling of this condition, you're handling
we're
well,
just
I
doing
think
whatever
so.
we can. I mean, here's what I tell myself. I mean, if I chose to be in this profession, there must be a reason, and I just go back to that reason, revisit it, and think, okay, I wanted to help people. I wanted to be there for them. I wanted to give them the best care possible, and that's what we're doing.
Okay. Just can you share your slide? We will check once. Is there any problem? Can you share?
Screen sharing is disabled on my end, so someone needs to enable my screen sharing.
Oh yes. Once can you share now? We'll check for the visibility.
No, not yet. So it says host disabled participant screen sharing.
Okay. Just a minute. Yes, I will do that. Yes, now I made you a host. I think now you are able to share your screen.
There we go. Can you see it?
Yes, it's coming. Yes, good. The visibility is good. No problem.
I'll just run the slides as well, just to be on the safe side. Don't worry about the references. I actually made them small intentionally.
Oh, yes, it's visible. Actually, we schedule for 2 o'clock. Just before 10 minutes, if you are checking, then it will be good, no?
Oh, well,
To
yeah,
avoid some.
absolutely. Yeah.
That is what. What is the time now?
It's nearly 9:30 in the morning.
9. 9
Yeah,
o'clock?
9:30.
Okay, half 9.
9:30.
Okay, okay, okay. Thank you so much for your acceptance.
Oh, absolutely. You know, I love teaching as a guest lecturer. And sit down with Ramarao sir in his office. You know, that would have been. I kind of had a mental note to myself to say, you know, I need to be there because of the current situation and everything. We are at least be able to actually do it online. So
Yes, definitely.
an
Being his
absolute pleasure.
student, and that is a mandatory thing. We used to love teaching.
Yes. Yeah. So is everyone in the college, or are they joining remotely?
Pardon, please.
Are everyone in the college? Is the college back open or?
No, just we are working from home.
Oh, okay.
Still, the government is not yet announced regarding the schools and colleges. Just
Okay.
we are taking online classes from home itself.
All
For
right.
all the
Yeah,
classes,
understood.
almost we started the next academic year for
Mm.
2020-21. Now we are continuing the theory classes. We hope that by the end of September or the first week of October, they may start. They may ask to start the college, and we hope that by the end of September we will move to the college.
It must be very challenging, you know, doing all the lectures online,
Uh,
and you don't know if you can't see the students most of the time, and it's not the same as the
for the
actual classroom environment, isn't it?
for the theory classes, it's okay. But difficulty with the practical B
Oh
pharmacy
yes,
and
yeah,
pharmacy
I
course, it's being
imagine.
majorly depend with the practical aspects. So that is a big challenge, really, what we are facing.
Hmm.
So I hope so. With the God's grace, by the end of September, we'll come. We'll come to the normal life. We are expecting that to be happen.
Hopefully, things are going great. So hopefully we will be having a vaccination. Hopefully, fingers crossed. Um, but the clinical trials that we are involved in our hospital, they are
Okay.
showing fruitful results as well. So um, we are managing well. The mortality rate is going down. So it's not as bad as we thought it would be. But we still shouldn't be letting our guard down, and we just need to actually keep fighting. That's the trouble.
But the government is trying here also not at on control. So day by day the cases are getting increasing, especially on Guntur. Every day the cases are getting increasing instead of decreasing by the month. We don't know. We can't say that. Even it may be extend up to December or so.
Mm. How is Ramarao sir? Is he doing well?
Yes, he is doing good. Sir is going to the college every day. He's going and he's having some administrative work.
All
So
right.
he's going and continuing the work. And just a minute, let me check for the participants.
Mm-hmm.
Am I audible to all?
Yes, ma'am.
Yes, ma'am.
A very good afternoon to one and all. Today we are having a guest lecture on management of kidney injury, acute kidney injury patients with heart failure. Here today we are having Dr. Ravi Kiran. He is working as a hospital pharmacist, Betsi Cadwaladr University Health Board, North Wales, United Kingdom. I take this privilege to introduce him. He is one of our alumni student also, first batch B Pharmacy student of Chalapathi Institute of Pharmaceutical Sciences. He has completed his Bachelor of Pharmacy in the year 2008 from Chalapathi Institute of Pharmaceutical Sciences. After that, he has completed MSc Pharmaceutical Analysis, PG Diploma of Pharmacy in Applied Therapeutics and Advanced Drug Delivery, Consultation Skills, and Postgraduate in Healthcare Management, and Post-Diploma in Non-Medical Prescribing, and MSc in Clinical Pharmacy. Currently, he is working as a hospital pharmacist in North Wales, United Kingdom. He has experienced with many posts like hospital pharmacist, lead pharmacist manager, and in this position he has continued from 2012 till date, and he is doing a good work there, handling of COVID patients especially now, and he is also experienced with the many aspects in the field of pharmacy, like medicine management, drug history, taking and medication reconciliation, organized medication supply to facilitate discharge planning, clinical verification of patient medication chart, reviewing patient medication aligned with current diagnosis, blood test results and clinical findings, identifying, escalating and reviewing medication interventions, and work as a part of multidisciplinary team to formulate a patient-centered pharmaceutical care plan. I'm welcoming you, Dr. Ravi Kiran. It is our privilege having here as a old student, alumni, and now as a guest lecturer. It's a privilege really. I'm thanking you for your immediate acceptance within a short span of time. Within 2 days of time, you are ready to give the guest lecture for our students. Thank you so much. And I request each and every student of the Pharm.D, this guest lecture is organized for you, only for the Pharm.D students. This is related to your pharmacotherapeutic subject from 2nd Pharm.D to the 6th Pharm.D student. Whoever attending here, please be attentive on your session. It is completely an interactive session. You can utilize him for the for 1 hour or 1 hour 15 minutes. Be interactive and be attentive for this session. So now I will hand over the session to Dr. Ravi Kiran. So please share your screen and you can start your session.
Thank you very much. Can you please enable my screen sharing if that's okay?
Yes.
Thanks.
Yes, now you can share your screen.
Thank you. So, hello everyone. Thank you very much for joining me in this session. And I'd like to extend my sincere gratitude to Chalapathi Institute of Pharmaceutical Sciences. I have the privilege to be one of the first proud students to graduate from Chalapathi Institute of Pharmaceutical Sciences. And we were the first batch, and whatever I am doing now is built on the foundation that Ramarao sir has actually taught us. So it is a great privilege on my side to actually give this lecture today in the college where I graduated from. So I am pretty certain you are in the best possible hands to learn pharmacy and pharmacy practice. So please do make the most of it. I kind of feel like, when I really do want to actually go back to where I started. And if I do have a second chance, I would actually utilize each and every minute and every possible professor that you've actually got. So telling a little bit more about me, you heard about my qualifications, you heard about my experience. But I am a dad of 3 children. This is what I do. I am very proud dad of a 5-year-old, a 3-year-old, and a 1-year-old. So that is me as a person, and I do enjoy having family days out and holidays with my kids. So I am also a human. So I do actually have a fun side to me. So today's session, I want it to be as interactive as possible, and I want it to be fun. I want you to learn from it. If there is anything at all that you don't understand, I do not mind saying it for the 200th time. So please don't shy away. We are here. We are actually sharing as a group. We are learning as a group, and we are going to develop as a group, because at the end of the day, learning is one part of it, and the second part of it is the application of it. So I am going to talk as much as I possibly can about the application of your knowledge. So I'm going to give you the knowledge, and we are also going to apply it. So now, to make it more interesting, you have a prize at the end of this session. You have a gift. So just to let you know, it is in your own interest. If not for the subject, at least for the gift, pay some attention. And there will be an interactive quiz, which is fun, at the end of the session. And there will be a leaderboard as well on the podium. So you'll be able to see which one of you actually did very well. So the more concentration you actually pay now, the quicker you will be able to answer, and the easier you will be able to be the winner. So it's not about how many answers you get right, it's about how quickly you actually get them right. Okay, so you need to have some fast fingers really, and you need to have access to internet, and you need to have your own devices, i.e. your laptops or your mobile screens, that you'll be able to use to access this quiz. So let's go right back in, and we shall start with the management of heart failure patients with AKI. So what is heart failure? There are various definitions, but I like this one much better, because it simply screams out ability is compromised in maintaining the circulation of the blood, which is impaired. It's either because of a structural defect in the heart, or it may be because of the functional effect of the heart. So I'll tell you what that means. So the structure of the heart itself, it might have changed, or the way the heart functions, i.e. the contraction and relaxation, has changed. Something somewhere has changed, which is impairing the maintenance of the circulation. So the able heart is failing to be able. So technically, to put it in one word, it is not pumping enough. It is not pumping as it should be. So the results include breathlessness, fluid retention, fatigue, and there are quite a lot of different words and everything. But what I want you to understand is, I want you to understand the mechanics. So we are going to talk about the anatomy and physiology for a little bit. It may be boring or it may be interesting, but let me put it this way. In hospitals, we call orthopedic surgeons carpenters. So They cut stuff, they put stuff together, they use nuts and bolts and stuff. We call the vascular surgeons and we call the cardiologists the plumbers. So they are worried about the motor that pumps the blood, heart, and they're also worried about different aspects of it, where the blood goes, and where there is a bit of a block, how to clear the block, how to put a stent in, and stuff like that. So they are the plumbers. So I want you to think like plumbers today, but I also want to change your perspective about how kidneys work, where we need to actually lay our focus, where we need to place our interest. Okay, so let's go into what the heart actually thinks is happening. Sorry, what the body thinks is happening. So when there is a heart failure, technically, as you can see in the figure here, there is a pool of blood underneath. Hang on. So there is a pool of blood underneath here. So the heart is not actually pumping as it should. This is a dilated heart. So the ventricle is dilated. It is twice as the size it should be. That's the reason why in a corner of the heart, there is some blood just stagnated. The blood is coming in and going out just right from here. Yeah, there isn't anything happening here. So what's happening is technically the heart loses its elasticity and it can't pump enough. And this is a weak heart. So the weak heart struggles, if you see what I mean. So what does the body think? When you are not being able to pump enough blood, the body thinks that you're either dehydrated, so there's not enough body fluids, or it thinks that you had an accident and there was a lot of blood loss. So there isn't enough blood, and that's the reason why you're not pumping it. But that is not the case, is it? It's actually the heart that is failing. So blood is always there. It is there, but it's not being able to be pumped very well. So the motor is not working very well. Think like a plumber. So you know about frail patients, you know about disability. There are a lot of symptoms that are common with old and fragile people and for heart people patients. So someone comes and says, oh, I feel weak, I had a loss of appetite, I am confused, and I have fatigue, I can't walk as long as I used to, and they are about 90 years old. You'll be saying, oh yeah, it's their old age. But think outside the box. Think, is it heart failure? Is it something else? So how do you know? So there are these two symptoms that are actually set apart, and they are particularly very, classic with heart failure. So if they say, oh, I have shortness of breath, and if their extremities like their ankles and their legs are swollen, then you'll be thinking, it's not just their old age, it's something else. So you need to dig down that route and you need to find out what exactly is happening there. So there are a few different types of heart failures. Let's talk about the systolic heart failure and then about the diastolic heart failure. So systolic heart failure, as it says, the heart contracts in systole and diastole. So the systole is when the heart pumps the blood out. It is when the heart squeezes, when the ventricles squeeze. So if the ventricles are not squeezing hard enough, then that is called a systolic heart failure. And if they can't relax hard enough, then it's called a diastolic heart failure. So what I want you to understand is there is only one way of diagnosing heart failure. That is by measuring the ejection fraction. So ejection fraction is the amount of blood, the volume of blood that's pumped out of the heart in a fraction compared to the total volume in the ventricle. So if there is 110 mils of blood in the ventricle, and if it's only pumping out 44 mils, then the ejection fraction is roughly equal to 40%. So technically, in a normal heart, the ejection fraction is 50 to 70%. In a heart failure, the ejection fraction is less than 40%. So it is a comparison to how much you have in here and what fraction of it is going out. So understand that very clearly, because that is what we are looking for. And this ejection fraction is only relevant to systolic heart failure. And I'll tell you why it is after we go forward. So when do you use ejection fraction as a measure to diagnose heart failure? Is only if it is a systolic heart failure. You can say, yeah, they've got a heart failure. If it is a diastolic heart failure, you won't be able to tell from the ejection fraction that they have a heart failure. The reason why is, like I said before, it is a fraction. So there is 69 mils in here, and 44 mils is getting flushed out of the heart, and you get an ejection fraction of 64. That's normal, isn't it? But what you need to understand as well is that there is an abnormal filling. There is a reduced preload. A preload is where you are trying to pump the blood in. If you think about it, previously we said in the systolic heart failure, the total volume in the ventricle is 110 mils. That's nowhere near 110 mils, if you see what I mean. So it's only 69 mils. So why did that happen? Why did that change happen? So this heart failure, systolic heart failure, usually happens when this muscle weakens. So technically, if they have a heart attack, a heart event, like a myocardial infarction. So myocardial infarction is the death of a part of a muscle in the heart, and because it is dead, it can't pump out enough. It doesn't have the same elasticity. It doesn't have the same strength. Or if the heart is dilated, this muscle here is thinner. If the muscle is thinner, the force at which it contracts is lower. And if the force is lower, the volume is lower. So that's how you need to understand it. In diastolic heart failure, our body has got a fantastic mechanism of compensating for itself. So what it does is it kind of realizes, okay, there's something going on wrong here. I'm losing my strength. So the myocytes, the muscle cells in this particular heart, they actually expand. So they actually build up. So the muscle wall here, as you can see, thickens. So that's great. You got a good force. You can contract and relax very well. That's absolutely brilliant, great. But we all know that it comes at a cost. So when the muscle wall thickens, it slowly decreases the volume of the left ventricle itself. So what's going out is less. And if less is going out, the rest of the body is going to struggle with that blood volume. And that yet again is a heart failure. So to put it simply, the heart struggles to relax. So if you look at this ball here, you can press it and it relaxes pretty quickly, yeah? You see this bottle here, you contract, you press that and you do the contraction, you put the lid on it. How long does it take for it to get back to its own shape? It doesn't, does it? So technically that is a good heart muscle, and this is not a very good heart muscle because it's actually thickened. Yeah, it's pretty hard for it to come back to its return back to its normal shape or normal size. And the blood is waiting here. It's saying, let me get in. Yeah, this needs to fill into the auricle and then into the ventricle, but it's still contracted. So all of this pressure is going to get backed up. And I'll tell you what happens because of that. So technically, here's a very good illustration of diastolic heart failure. So a healthy heart pumps out more water, as you can see. More water, which means more blood is going out. That is a healthy heart. But because the muscle of the heart is thick, the ventricle size is lesser and less water pumps out. And that's what we call a diastolic heart failure. So what happens because of all of this is technically the ejection fraction is reduced. Or shall I say, the amount of blood that is going out of the heart is reduced. How did that happen? What is happening there? What is contributing to it is these four different factors. Like I said, the thickening of the heart muscle, or the when the heart ventricle dilates, that is hypertrophy of the myocardium, which is the muscle around muscle of the heart. Or sometimes what heart does is, oh, okay, I'm not pumping enough blood. Let me increase the heart rate. So let me contract for more times a minute. That can actually do that as well. The renin-angiotensin and aldosterone system is something that actually regulates the fluid dynamics in the body. You might have all known about this. And that activates, it says, oh, okay, because the heart is not, what happens when the heart is not pumping enough blood is the kidneys don't get enough blood. When the kidneys don't get enough blood, they kind of realize it that, you know, oh, there is not enough blood in the body, or the blood is lost, or we are dehydrated. Outside. Thank you. Thank you. Sorry about that, guys. So, so what happens when the kidneys don't have enough blood is they think that there is not enough blood, but that is not the case. The blood is there, but it's just that the heart is not being able to pump it enough. So what the kidneys think is, okay, we need to increase the blood volume. So they do less diuresis, i.e., they send out less urine, and they retain a lot of fluid. They retain a lot of water and salt, and that in turn will increase the pressure on the heart. And because heart is already struggling, the last thing that it wants to do is actually have more blood to pump out and more blood to circulate. Just give me 1 second. So technically, the kidneys actually understand that as dehydration, and they keep a lot of water and salts. And that is not good for the heart, because the heart is already working hard enough. All it needs is a lot more workload on top of that. Okay. So that is what usually happens. And a sec. And so it is quite important for us to make the kidney understand there is actually heart failure, and it is not the fluid itself. So what we need to tell the kidney is, don't worry too much. So there are quite a few different types of heart failure. For the New York Heart Foundation, they actually give different classes of heart failure. So this 1, 2, 3, and 4 are based on the patient's symptoms, what the patient's physical activity is like, how much discomfort they are in, and so on and so forth. And this is based on science. So this is based on the evidence of what's actually happening to the heart. You know, they do an echocardiogram. That is the only way. Remember, echocardiogram is the only way you can diagnose heart failure. So you can't just diagnose it from your blood pressure. You can't diagnose it from the ECG. You can only suspect it. But the only way to diagnose a heart failure is when they do an echocardiogram. So enough about heart. Let's talk about kidneys. So what is an AKI? AKI is an acute kidney injury. Sorry, I didn't put that down there because it's quite commonly used term for us. AKI is acute kidney injury. So acute kidney injury is when there is a raise in serum creatinine of 26 micromole per liter or greater within 48 hours. So when you are practicing, this will be pretty much your bread and butter. You actually see the patients day in, day out, and you actually look at their blood test results. And this is what you need to watch out for. You need to watch out for any sudden raise in the serum creatinine. Or it is also a fall in urine output. So if the urine output is less than 0.5 mils per kilogram per hour, so for an 80 kilogram man, they should be excreting an average of 40 mils per hour. And if they're not doing it, that means that the kidneys are not working enough. Or in our case of the heart failure patient, the kidneys have decided not to work enough. So what happens then is the kidney is already suffocated from blood flow. It doesn't have enough blood flow. And on top of it, it is actually keeping a lot more fluids in. The heart is not pumping enough. It all gets into a vicious circle where the kidney is actually under a lot of pressure. It can't pump out. So it can't pump out because it's keeping a lot of fluid, but there is already congestion there because the heart is not working enough. That all is backed up. So the kidney wants to send the retained water back into the system, but the system is already fluid overloaded because the heart is not pumping enough. So it can't send it out. So the kidneys actually, they struggle to pump out, and they're also struggling to get it in. So what happens to the kidneys? They are under a lot of pressure as well. So the heart is under a lot of pressure, the kidneys are under a lot of pressure. It is a mess. So technically, a heart failure patient with an AKI is kind of like a double system failure, and you need to work quickly. So in a patient without an AKI, without a heart failure, usually you stop a lot of medications. You stop anything that is very not so good for the kidney, like we call them DAM drugs. So that's diuretics, ACE inhibitors, which is angiotensin converting enzyme inhibitors, all your ramipril, lisinopril, tadalafil, and stuff like that. And also ARBs, which is angiotensin 2 receptor blockers, like your sartans, which is losartan, candesartan, telmisartan, and stuff like those. So diuretics, ACE inhibitors, ARBs, angiotensin 2 receptor blockers, metformin, which is an anti-diabetic drug, NSAIDs, which is the non-steroidal anti-inflammatory drugs like your diclofenac, your ibuprofen, and stuff like that. All of these are determined to be not so friendly with the kidney, so they actually do make the kidney struggle. So what we do as soon as we see an AKI, as soon as we have an indication that the kidney is struggling, is we want to take those away. We want to get rid of them, and make sure that we give a bit of a breathing space for the kidney. We want to let the kidney heal and get back to its normal function. So that's what we normally do. Now look at the different medications that we use for heart failure. What screams at you? You're using diuretics. You're using ramipril, which is a kind of a ACE inhibitor. You're using candesartan. You're using furosemide. So all of these are not kidney friendly. So you have a heart failure patient and the kidneys are not doing well. What should you do? Do you stop them? So that is where I am going to concentrate my discussion on today. So the answer is, it looks like you should stop them, but you shouldn't stop them. When should you be stopping them is what this discussion is all about. So you have a heart failure patient, they got admitted, 2 days later, they developed an acute kidney injury, the kidneys are not doing so well. You think, oh, okay, I know what to do. I'm going to stop the diuretics, I'm going to stop the ACE inhibitors, I'm going to stop the ARBs. No, hold on. You need to actually see where and when and how you need to actually manage it. Because if you stop any of those, they are going to have adverse effect. The heart failure is going to get worse, and eventually, that is going to cause a lot of problems with the kidneys. So technically, the patient will die because of your decision. So it is very important for you to understand when and how and where you need to actually stop these particular medications. So technically, I'm going to call them a RAS. RAS stands for renin-angiotensin-aldosterone system. So RAS inhibitors are anything that actually that actually interrupt the renin-angiotensin and aldosterone system. So let's call the RAS inhibitors as ACE inhibitors and ARBs. So angiotensin converting enzyme inhibitors and angiotensin 2 receptor blockers. Let's call them RAS inhibitors for this discussion. So if a heart failure patient had an AKI, which medications do you stop or reduce? How confident are you? And this is where I am coming to help you to give you a bit of an insight into when you need to reduce or when you need to stop the RAS inhibitors. So is there any guidance? Yes, there are some clinical knowledge summaries which actually say, like NICE is the National Institute of Clinical Excellence in the UK, and they say, oh, try reducing this dose or stopping the dose of ACE inhibitors or ARBs when the serum creatinine raises by more than 30%. There isn't any other explanation. They say, yeah, reduce or stop. How do you know? And there are European Society of Cardiology guidelines. They say, oh, okay, it's not 30%, it's actually 50%. Or if the kidney function is 266 micromoles per liter, then stop it, or then reduce it, or then withdraw it. So it's all a bit blasé. There is no confirmed guidelines or guidance or particular measure to say this is where and this is when you need to stop. You need to stop things and you need to reduce things, or you need to think about reducing them. So there was a fantastic publication in 2019 by Clara, and I'll show that to you. But before I show that, I want to change your perspective about acute kidney injury or renal dysfunction in heart failure patients. So there was a clinical trial called SOLVED. In that clinical trial, what they used was enalapril. So they used enalapril in few patients, and they used placebo in few patients. So 50% of the patients had enalapril, and 50% of the patients had placebos. So let's call them 100 patients had enalapril, and 100 patients had placebos. So in 100 patients who had enalapril, 16% of the patients had a raise more than 44 micromoles per liter of serum creatinine, which is an AKI, isn't it? It was only 28 if you remember it. So 16% of the patients actually had raised serum creatinine. But in the placebo arm, only 12% had the raise in serum creatinine. If you think about it, to put a perspective, it's only 4%. So technically, if you use enalapril or if you don't use enalapril, it is not going to make much difference. They're going to probably have a kidney dysfunction anyway. And the difference is only 4%. So if you think about it, heart failure patients, even if you don't give them any RAS inhibitors, they are still going to go into an AKI. So should you be really stopping it? That's where the discussion comes in. So like I said, this is a nephron. This is what is happening. So a nephron is responsible for filtration, reabsorption, secretion, and excretion. So why that particular kidney dysfunction is happening is because the blood that is going into the kidneys is reduced. Yeah. And likewise, the kidney is retaining as much water as it possibly can and sending it out. But the urine output is reduced as well, unfortunately, because the amount coming in is reduced, the urine output is reduced. So a lot of creatinine actually stays in. The kidneys are going to struggle, and that is where, and they are not being able to send it back into the blood flow because the blood flow itself is backed up because heart somewhere over here is not pumping enough. So there is a lot of queue. The queue is building up, and you can't send more people in when the queue is building up. So it is all going to back up, and the kidneys are going to struggle. So that's the reason why you are having a bit of an AKI. So what is the measure? So like I said, this is from one of the European heart journals where they actually had a look at the chronic kidney disease in heart failure with reduced ejection fraction. And just give me 1 second, guys. So sorry about that. So what's going to happen is in the trial they actually had few people on ACE inhibitors, few people on ARBs, and MRAs is your class of drugs like spironolactone and eplerenone. They are diuretics, but they are potassium sparing, and they have a fantastic function in heart failure. But that's for another discussion. Let's concentrate on kidney function and heart failure. So this is the number of patients that lived, and they mapped it against the glomerular filtration rate, which is a measure for the kidney function. So where should the kidney function be? Where did we actually see the utmost number of patients surviving is what we are looking at. So technically, in a healthy person, we expect the kidney function to be anywhere in between 90 to 100 because we want 100% of kidney function, to put it in a perspective. Anything less than 100% is like kidney dysfunction, but not exactly, but I'm saying 100% is where a healthy person's kidney function should be. And what happened here is surprising. So people with nearly 100% of their kidney function, not many of them survived. So as you go into 90%, 80%, 70%, and 60%, you actually see that people who actually had 60% of renal function, so 60 mils per minute of their renal function, those heart failure patients actually showed less mortality. So less amount of people died and more people survived. So you need to understand it very, very clearly that when you have a heart failure patient, your aim of your kidney function should be 60 mils per minute, not 100 mils per minute like we do for healthy people. It should be 60 mils per minute. So if you see someone drop from 100 to 70, you shouldn't be thinking, oh my God, their renal function is declining, and don't stop the RAS inhibitors, okay? So anything between 50 and 60 is a good place where you want to be because you want that patient to live for longer. So that is what you need to aim for. You shouldn't be aiming for 100. So change that perspective. A loss in kidney function in a heart failure patient happens. It just happens. And when it happens, you need to understand that you want to keep their kidney function between 60 mils per minute, 50 mils per minute, and 60 mils per minute, not 100 mils per minute. Because if you keep that at 100 mils per minute, then it is going to actually have adverse effect on the heart. The heart failure gets worse and the patient actually dies quicker. So that is a little bit of a perspective as to where you need to actually place your interest. So let's say that this is the pass mark, yeah? So many people are there, you know, many students are there at the pass mark and not many people are there at distinction. So you want to be with the group, yeah? So you want to be where there is a majority of a survival rate than place where you actually probably, you know, don't survive very much. So that is a change of perspective. But yet again, if you see as the kidney function decreases, so if it goes less than 20 mils per minute, then unfortunately, you know, that is going to cause a lot of kidney dysfunction, and the renal side of the things start getting worse, not the heart side of the things, and thereby the patient dies. So we got that cleared. So when a patient gets admitted into the hospital, they have a heart failure, they have AKI, we changed our perspective. We started thinking, okay, yeah, we want their kidney function to be 60 mils per minute. Grand, let's carry on. Now, think about, are there any other reasons for this acute kidney injury? Are there any reasons why the kidney function has decreased? Think about it first before you jump into this 60 mils per minute per hour. So let's have a look at the other causes of AKI: infections, injuries, surgery. If you have a severe diarrhea, if they have severe allergic reactions like anaphylaxis, all of those can cause kidney injury. So you need to have that at the back of your mind when you are actually looking at it and thinking, oh, okay, yeah, this guy has heart failure, he's going to have kidney injury anyway. Probably not. One of the reasons might be that infections or severe diarrhea are things like that. Get those out of the way, and the kidney function improves. Everything is back to normal. So think about that. Treat it for what it is. So the other reasons why there may be a fluid retention, because heart failure can actually lead to a lot of backlog. And like I said, the Q increases and a lot of fluid gets retained. The kidneys save a lot of water and salts, and then there will be swollen ankles, and there'll be water accumulation in the abdomen around the liver. All of this happens. Yes, great. So you can't just put it down to, oh yeah, they have heart failure, the kidneys are not working very well. That's why they are retaining fluid. No, get rid of the other factors first. Think about the other factors first. Think about the simple factors first. Simplicity is the best policy. So is it because they are not mobile? Is it because they are sitting and standing, or they are lying down in a particular position for a very, very, very long time? Because that does happen in old people. They can't be bothered to get out of the bed. And is that the reason why the fluid is retained? Are there any hormonal changes? Particularly, there are a few hormones like antidiuretic hormone that is secreted by your pituitary. What that does is it actually stops you from flushing water out. So it actually keeps a lot of salts, and it actually just lets the water go out. And because of that, the salt actually accumulates, and then there will be a lot of fluid dynamic changes there. So what actually is happening here? So after you actually get rid of those causes, you have a very small window of adjustment to the fluid overload. So the fluid is overloaded. It's like a pumped up balloon. There isn't much chance for you to, increase the fluids or stuff like that. So what you need to do is you need to reduce the amount of fluids. So you need to get that balloon back to where it should be. So you need to say to the kidneys, actually, pump the water out. Don't retain the water. How are you going to do that? You give them more diuretics. You give them more diuretics and the water goes out. There is a reduction in the blood volume. It's back to where it should be. The pressure on the heart reduces. The pressure on the kidney reduces. Win-win. So that's the reason why you need to continue the RAS inhibitors, because you don't want the blood pressure to go high. So you still want to give your ACE inhibitors and ARBs. What that does in turn, even though it is not friendly with the kidneys, it actually reduces the blood pressure. When the blood pressure reduces, then automatically the flow of the blood into the heart as well is reduced, and that actually buys a little bit more time for your heart. Because what you need to understand is blood pressure exists in arteries and veins. So blood is flowing in both places. So what we need to actually make sure is that the venous blood pressure, which actually is going to take the blood back to the heart, that actually has an effect that is actually saying, okay, come on, I have to actually give you more blood, pump it out as soon as you can. When you use RAS inhibitors, you're only thinking about the arteries. You're thinking, oh, okay, not enough blood is getting pumped out. If not enough blood is getting pumped out, the blood pressure is less. No, that is not how it works. You also need to think about the veins as well. You also need to think about the Q. So what we are doing by using the RAS inhibitors, you are reducing the Q. So the workload is getting reduced. And the heart actually has a little bit more time to actually pump out the blood and then accept a little bit more in. So you're actually reducing the pressure on the heart. Because remember, the main problem is heart failure. It is not the kidneys. But you can't ignore the kidneys either, but that's not the point. What you need to remember is the kidneys are not injured. The kidneys are not affected. It is not a kidney disease. It is the fluid dynamics, the dynamics of the blood that has changed. Think like a plumber. So patient gets admitted in the hospital, they have low blood pressure, and a nurse comes and says to you, they have low blood pressure, I'm going to give them some saline. Let's hang some saline. Let's give them some more body fluids. Do you want them to do it? No, because there is already more fluid in the body, and you don't want to give them more fluid. That's going to put more pressure on the kidneys and the heart. So low blood pressure doesn't always mean less body fluid. So when someone has a low blood pressure, think outside the box. Think about, okay, what else is there? Is there any shortness of breath? Is it worse when they are lying down? So can we do an echocardiogram? Can we actually see if it is a heart failure? If it is a heart failure, you shouldn't be giving them any more fluids. So think about it. Make sure that it doesn't happen. So what is the measure? How are we going to know when to reduce the RAS inhibitors? So first of all, clinical assessment, when they come into the hospital, compare their base renal function. Take their renal function in the last few months and see where their normal renal function is, and think about the fluid status. Like you can actually see the jugular venous pulse. If it is not visible, that means that there is a postural drop, i.e. the blood is not pumping enough into your jugular vein. And consider the causes. Why is this happening? What are the things? Like I said, think simple. First think about what is happening and why is this particular problem happening, and are there any other causes like infection or stuff like that. And only if there is a symptomatic hypotension. Symptomatic hypotension is when the patient stands up, there isn't enough blood flow to the brain, they feel dizzy, they fall down. That's symptomatic hypotension. If there is a symptomatic hypotension, then you need to reduce the RAS inhibitors. If not, don't. You also need to do a lot of clinical and biochemical assessments, like you need to do the urea and electrolytes and creatinine to actually get a picture of how well the kidneys are working. What different types of electrolytes are they storing? Like, are they storing more sodium, more potassium? Because that actually has got an ionotropic effect on the heart as well. So you need to think about that side of things. Just keep the whole picture in front of you, and assess them clinically and biochemically. See what's happening, and think about the severe renal function as well. Is it the kidneys? Something happened to the kidneys? Is it really the kidney injury? Are the kidneys dying? Think about that as well. Is that the reason why the renal function is changing? So think kidney, think heart, think simple. Get a whole picture before you make a decision. So now, here comes the actual answer that I want you to understand. I'm saying it as clearly as I possibly can. This is one thing I want you to take away from this session. This is it. So don't get too confused with that HFPEF and HFREF. HFPEF is heart failure with preserved ejection fraction. That's technically your diastolic heart failure. HFREF is heart failure with reduced ejection fraction, which is your systolic heart failure. We go back to the slides. Systolic heart failure has low ejection fraction, as you can see. That's a reduced ejection fraction. Diastolic heart failure doesn't have a reduced ejection fraction, so that's HFPEF, which is heart failure with preserved ejection fraction, and that is HFREF, heart failure with reduced ejection fraction. This is where we are concentrating, yeah? So systolic heart failure is where we are concentrating, because that actually happens in more people than diastolic heart failure. So if there is a preserved ejection fraction, there isn't anything you need to do. You can just stop it. You can consider to stop it if the serum creatinine increases less than 30%, because there isn't much you can actually do, because the ejection fraction is pretty much preserved, isn't it? If you think about it, the heart has compensated for it. It actually built up a little bit more of muscle. So there isn't, you can't pretty much reduce the stress on the heart, because the heart is not stressed, because it's already had its own compensatory mechanism. It realized that it is getting weak, it builds some muscle, it's pumping, the heart is happy. But not enough blood is going out, that's a different story. But using the RAS inhibitors, what we are doing is we are reducing the stress on the heart. So particularly in heart failure with reduced ejection fraction, the heart is struggling. The heart is struggling, and we want to reduce the stress on the heart. So if the serum creatinine has raised less than 30%, continue unless there is a symptomatic hypertension, like I said before. If it is between 30 to 50% increase in serum creatinine, then probably you should consider a temporary withdrawal. So just for a couple of days to see, give a bit of a breathing space for the heart, so for the kidneys, and the kidneys actually recover, and hopefully, then you can put them back on the RAS inhibitors. If there is a serum creatinine raise of more than 50%, definitely, definitely temporarily stop it, because you need to give a bit of a breathing space. That's less than 50% of the normal kidney function, and greater than 50% raise in serum creatinine. So it's not in a good place. So you should temporarily stop it for a couple of days. Definitely stop it. Here, think about stopping it. Here, don't stop it here, and think about stopping it here if it is between 30 and 50, and definitely temporarily stop it here. And if the renal function is severe, which is if the glomerular filtration rate is less than 20 mils per minute, then definitely stop it, guys, because the kidneys are struggling. So you need to put the kidneys first before the heart in this particular case, because the kidneys are really, really struggling. And stop the RAS inhibitors. RAS inhibitors are your ACE inhibitors, like the angiotensin converting enzyme inhibitor, ramipril, lisinopril, tadalafil, and stuff like that. And RAS inhibitors also have ARBs, angiotensin 2 converting enzyme inhibitors, angiotensin 2 receptor blockers, which are your losartan, candesartan, telmisartan, valsartan, and stuff like that. These ones should be stopped if the renal function is less than 20 mils per minute. So here are the different steps that you need to remember. Less than 30%, continue. In heart failure with reduced ejection fraction, we are not talking about this one because it's irrelevant to talk about RAS inhibitors here, to be honest. Increased raise in creatinine of 30 to 50%, think about stopping it. Greater than 50%, temporarily stop it. If the eGFR is less than 20 mils per minute, definitely stop it. This is what I want you to take away from this lesson or from this lecture. Take a screenshot, save it somewhere. It is going to be really useful when you actually start practicing as a pharmacist. So what happens is, because people are on different regimens, because ramipril, as you know, one of or any of the ACE inhibitors, the side effect is they cause hyperkalemia, which is the raise of potassium in your blood. If the kidneys are not working very well and you're continuing the ramipril, you need to make sure that you're actually measuring the potassium every day, technically, because you want to see where the potassium is at. And because if you actually give them more potassium, then that might probably have a little more adverse effect on the contractility and the electrochemical balance of the heart muscle. So that in turn can actually cause more problems. So patients do develop hyperkalemia technically if you actually continue the RAS inhibitors, and if they are on if they have heart failure and if they have acute kidney injury. Don't see the high potassium and stop it altogether. So that's another place where doctors get it wrong. They see a rise in serum potassium and they think, oh, this is caused by ACE inhibitors, I'm going to stop that. No, don't do that. If you stop that, the heart is going to struggle even more. Now you need to understand when you need to stop the RAS inhibitors in comparison with the potassium. There's a little slide. I don't want to bore you with it, but technically, until unless it is really, really, really bad, don't stop it. So things actually get a little bit out of hand. They do get out of hand. So mild hyperkalemia, 5.5 to 5.9, do not withhold RAS inhibitors. But it all depends on how clinically well the patient is. So patient clinically unwell with sepsis or hypovolemia or AKI, patient clinically unwell with decompensated heart failure with or without AKI, even then, just have a look. Think about the whole fluid dynamics. Think like a plumber, and follow these guidelines. These are not guidelines as such. This is just a suggestion, shall I say. This is just a little bit of a perspective to think about. So don't follow them like a guideline, but this actually helps your thought process. This helps your way of thinking. So have a look at it as a whole, but think about it this way. The minute you stop the RAS inhibitors, the time starts ticking for the heart and it is going to be overburdened. So have a screenshot of that. The more you practice it, the more patients you see, patient-to-patient basis, the more discussions you have with the doctors about their care and about their pharmacological management, the better it will be. Then you'll be able to actually understand it better. So don't worry too much about retaining it all at this particular point of time. It will come with practice, but that is another reason where people actually stop the RAS inhibitors. But what I am trying to do is buy a little bit more time. RAS inhibitors are good for your heart, and don't stop them straight away. And hold back and know about when you should be thinking about stopping them or when you should be temporarily stopping them. And I'm giving you 3 different perspectives. One is your blood pressure, if how severely hypotensive is the patient. And the second one is your kidney function. That's again another reason why they actually stop it. The third one is the serum potassium. That is the third reason why they stop it. So there are 3 different reasons. Once a patient gets into the hospital, when they think of, oh yeah, okay, yeah, stop the ramipril. No, don't. Think about it. Have a look, and think about it in the whole perspective. Do the clinical assessment. Do the biochemical assessment. Do the physiological assessment of the patient, and think about it as a whole. And let the patient know that stopping the RAS inhibitors may actually be detrimental for the patient. Sorry, let the doctors know that that stopping the RAS inhibitors may have adverse effect in patients with heart failure. So it's all great. So the patient is on established RAS inhibitor, and he's presenting unwell with AKI, and they have WRF there is worsening renal function. So AKI is actually going even further. The renal function is worsening. So what do you need to do then? So like I said, think about fluid overload, think about hypertension, think about if there are any other causes. And if there are any other causes, then think about the heart failure patient in general, because after a while, the heart failure patient actually has got less chance of surviving. And think about if the RAS inhibitors are actually going to do any good for them or not, and think about stopping them if possibly can. But here is another way of thinking about decompensated heart failure. Unfortunately, because of the time limitation, I can't tell you what decompensated heart failure is. I wish I can, but this is only a snapshot of thinking and changing your perspective, because this is where many people are getting it wrong. And I know that many people are, because my hospital and in other hospitals in Manchester and Sheffield as well, I actually have spoken to other pharmacists who actually voice the same concerns. And we were all very, very happy when we were all very delighted to actually see this article when it got published by Clark Hall and Kalra in 2019 in one of the heart journals, because this is an article written by nephrologists and also the cardiologists. So it is heart and kidney doctors, the specialists, speaking to each other and saying, okay, this is where we need to actually lay a bit of a foundation, lay a bit of a guidance as to say, this is how we should work in the benefit, for the benefit of the patient. So have a look at the article. The article is actually mentioned right down here. It's change in renal function associated with drug treatment and heart failure. Have a look at it. And it's also published in the European Society of Cardiology guidelines. It is slowly getting included. So probably after they do more observation and more clinical trials, you will be actually having proper guidelines with regards to when and where you need to do what. But follow your local guidelines, follow the hospital guidelines, speak to another pharmacist if you want to. But think this. Yes, you need to think kidneys, but you also need to think heart. Which one comes first? It's hard to choose. But stopping the RAS inhibitors actually is not going to be so good for the heart, and hence it is not going to be so good for the kidneys. So if you stop the RAS inhibitors, you think you are doing a good thing for the kidney, but actually you're not. You're going to lose kidney and heart. But if you continue the RAS inhibitors, you will win the heart, and in time you will win the heart, win the kidneys back as well. So think about it in that way, and think twice before you stop the RAS inhibitors. But again, be vigilant about the hypertension. Be vigilant about the bigger picture, the whole picture. Take a step back, look at everything in detail before you actually make your decision. Okay. So thank you very much for this opportunity, and I am open for any questions if you have, if any one of you have any questions.
Students, you can interact yourself. You can unmute your system. Then you can ask your questions. Please be interactive.
Madam, please can you unmute them? I don't know how to unmute them. I made you the host again.
Okay. Just a minute. I will do it. Yes, I made it. Students, now you can unmute your system. You can ask your doubts. No one is having any doubt on this?
Sir,
Yes.
Yeah.
sir,
Can you hear me now?
in which condition we observe systemic congestion, sir?
Sorry, I can't hear you very well. Can you speak up, please?
In which condition we observe systemic congestion, sir?
In which condition do we are in systemic condition? I don't understand the question. Sorry.
Systemic congestion, sir.
Systemic congestion.
Yes, sir.
Yeah. So what is the question about systemic congestion again? Sorry. In which condition do we have the systemic congestion? Is that what you're asking?
In which condition we observe ventricular or left ventricular or right ventricle failure, sir?
Right. Okay. So there is left ventricular failure and right ventricular failure, but left ventricular failure is more prevalent. It is very, very common, and usually right ventricular failure is due to the left ventricular failure as well. The systemic congestion happens in both cases, because if you think about it, the left ventricle actually gets the oxygenated blood from the pulmonary vein, and if there is a congestion in the left ventricle, that's going to back up into the lungs, and then it is going to back up into the systemic as well. But most prominently, the systemic congestion happens in the right ventricle, where the veins are, where we are actually trying to supply out the deoxygenated blood into the lungs, and that is going to actually have an adverse effect on the artery, on the auricle itself. And when the auricle can actually pump the blood into the ventricle, into the right ventricle, then that is all going to back up, and that is going to give the systemic congestion. But any kind of heart failure can actually cause systemic congestion. It depends on how far gone the heart failure is, how bad the heart failure is, and how much congestion there is. Did that answer your question?
Yes, sir.
It did?
Yes, sir.
Okay, thank you, Pravalika.
Thank you.
Any
sir.
more questions for me?
Good afternoon, sir.
Hello, Lavanya. How can I help you?
Sir, what is the fate of ejection fraction in the case of both systolic and diastolic heart failure? If a patient is suffering with both systolic and diastolic heart failure?
It is a bit unlikely, but it does happen. What happens then is we need to look at the echocardiogram in general. So, like I said, in diastolic heart failure, usually if it's diastolic heart failure on its own, the ejection fraction is pretty much okay. But if it is a combination of systolic, so it can't contract very well and it can't relax very well, the ejection fraction is going to be affected anyway. Yeah. So because it can't squeeze very well, the ejection fraction will be less. And because it can't relax very well, what happens then is it's going to actually have congestion backed up and back into the systemic circulation, and that again can actually cause problems. So ejection fraction is going to be reduced in patients with systolic and diastolic heart failure, but mainly because of the systolic heart failure. So systolic heart failure is the inability to pump the blood out. Diastolic heart failure, it pumps the blood out, but it doesn't pump enough.
Okay, sir. Thank you.
Does that answer your question?
Yes, sir.
Thank you, Lavanya. Any more questions for me, guys? Any slides you want me to go back to, just let me know. Last chance. Okay, fine, fair enough. So now, let's going to do a little quiz, like I said before. So I believe that learning needs to be fun, and I am a visual learner. I learn from looking at things. If there are too many words and too many letters on the screen, it doesn't get into my head. That's the reason why I actually gave you a lot of interactive images and I put a lot of pictures in. Hopefully something got in. And now in this quiz, I have intentionally included some distracting images to make it challenging for you guys. So those of you who concentrated really, really well, you should be able to whiz through this quiz, okay? You should be able to fly through it. Those of you who haven't, you might not be so quick. So there is a prize in the end. I'm pretty certain Chalapathi Institute of Pharmaceutical Sciences would be able to make it a grand prize. But this is what I want. Do not, I repeat, do not get the fifth question wrong. Please don't get the fifth question wrong, and I'll be very, very disappointed in myself as a teacher. So let's go back, and can you still see my screen?
Yes, sir.
Yes.
Yes, sir.
Yes, sir.
Okay, good, good. Thank you. So what I'm going to do is we're going to play a little quiz. Okay, are you guys ready to join? So that's what you need to do. Go on to that website there and put the game pin in. So go on to www.kahoot.it and put the game pin in. That's the game pin.
Actually, it is not displayed here, Ravi Kiran.
Sorry, madam, what did you say?
Actually, it is not displayed here. Are you showing any website?
Hello?
No.
No, ma'am.
Okay, okay.
Hello? Is anyone having trouble joining the quiz?
Sir, there is no link
Hello?
provided in this slide.
There is no link provided.
Sir, actually, whether are you showing any link for the students, sir?
Yes, I am. Just give me 1 second. Can
Yes,
you
sir.
see my
Because,
screen?
we can see the screen, sir, but on the screen we have just only identified that what is learning if it is not no fun. On that slide is being
Okay.
displayed. We're
Okay,
not
just give
getting
me 1
any
second.
web page.
Just give me 1 second. So can you see my
Okay,
cursor?
sir. Yes, sir. I'm seeing, sir.
So that's the website.
Yes, now
Okay,
it's
sir.
visible. Okay.
1194711. The game pin, yeah? Okay, I can see one player, RK, joined. There we go. Only first 50 players will get in, guys. So you have to be quick. See 9 players so far. Sam, good. I'm going to give you 2 more minutes, guys.
Oh.
We have 72 participants and only 15 players. Come on. Okay, just 1 more minute. Okay, shall we get going? Oh no, some more. Okay, guys. I guess this is it. Okay, let's start. So, this game is about how quickly you respond. It's not about how many answers you get right, yeah? This is about how quickly you respond. Obviously, you need to get the answer right. If you get the answer right, you get points. If you don't get the answer right, you don't. So you need to be able to act very, very quickly on your fingers. It is very simple. let's go for it. You will. I'm sure you'll have fun. Very good. 5 of you got right. Who answered death? Body doesn't think about heart failure like death. Yeah, okay. So this is about what body thinks about heart failure. So it thinks that you had a blood loss or you're dehydrated. Okay. So let's see who got this right and who got this right pretty quickly. Ravi, it's definitely not me. There is another Ravi somewhere. Well done, guys. Bharati got it right next as well. Yeah, Sriman Kinnara, you're the top 5. Very good. So next question, get ready. Six people got it right. So low blood pressure in heart failure is not due to less body fluids. It is because the heart is not being able to pump enough. So that's what the kidneys think as well. The kidneys think that the body fluids are less. The kidneys think, okay, there is dehydration. The kidneys also think, oh, there might have been blood loss, but no, that is not the case. It's just that the heart is failing to pump very well. So it is not the kidneys that are affected, guys. Remember, it is not about the body fluids, it's not about the kidneys. It is about the heart itself. It's the fluid dynamics. Okay. All right. Let's get ready to see who got this right. Ravi, no. KK is charting on the top. Very good. Ravi fell down to 3rd place. Very good. Lavanya in 2nd. Okay, let's keep going, guys. You're doing well. Next question. So which of the following is not a RAS inhibitor? Very good. I'm so glad. 16 of you got it right. Very well done. Very well done. Let's see who charted on the top this time. Lavanya is in the lead now. Okay, good, good. Next question, guys. Get ready. Only 2 of you got it right. So 60% of the renal function is where you actually see less mortality, right? That is correct. So remember that little chart where I actually went up to and I said, oh, a normal renal function is 100% and it's 100 mils per minute, but you don't want to think about it like that, okay? And it's not 100%. It's many of you actually answered 30%, but it's not 30% either. So it's 50 to 60, but 60 was the peak you actually saw at the highest. So that's where